A very good afternoon, everybody. I'll be presenting on the topic novel approach of retrobulbar amphotericin B to tackle orbital mucormycosis. I have no financial interest. Mucormycosis is transmitted by inhalation of spores or by direct inoculation of the spores into the disrupted skin or mucosa, which leads to a high mortality among immunocompromised by alteration of their immune system. India was badly affected by the second wave of COVID-19, causing a high mortality in immunocompromised, mainly post-COVID-19 and diabetic patients. COVID-19 pandemic has witnessed a resurgence of the cases of rhinoorbital mucormycosis. This study documents these cases and their management with this novel approach of retrobulbar amphotericin B in halting orbital infections. The study was carried out for a period of 8 months at our tertiary hospital from Jan 2021 to June 2021. It's a prospective interventional institutional study and the enrollment was carried out till the end of June 2021. Thereafter, a minimum follow-up period for 60 days was taken. Informed consent was obtained and approval of local ethics committee was obtained. A positive RT-PCR reaction of nasopharyngeal or oral swab with history of COVID-19 were confirmed. A complete history taking including ocular complaints was taken from every patient. All the cases presenting with the complaints of facial pain and swelling, toothache, nose block, ptosis, ophthalmoplegia, sudden loss of vision, black astro over palate, lid, conjunctiva, cornea were thoroughly evaluated by a team of physician, ENT surgeons, ophthalmologists, neurosurgeons, and maxillofacial surgeons. We define proven mucormycosis as those patients having clinically compatible signs and symptoms and demonstration of fungi in their tissues or body fluid, either by direct microscopy or culture. Patients who were negative on direct microscopy and diagnostic nasal endoscopy were treated as non-mucor patients by respective departments and were not included in our study. A complete ophthalmic examination, which included visual acuity, extraocular movements, slit lamp biomicroscopy and fundus examination was done. Imaging of both the orbits, brain and paranasal air sinus with or without contrast was done using MRI and CT scan to know the extent of the disease. A complete hemogram, blood sugar and renal function test of all the patients were done. On the basis of the involvement, we staged our patients as stage 1 showing nose and paranasal air sinus involvement, stage 2 as nose, PNS and orbital involvement, and stage 3 is stage 2 plus involvement of brain. Intravenous liposomal ampho B was given only after a confirmed microbiological or histopath diagnosis of mucor to all the patients under physician's guidance in a dose of 3 to 5 mg per kg body weight per day. Sinus debridement was done on the ENT side. Patients with stage 2 and stage 3 disease were given ampho B at a dose of 3.5 mg per ml via retrobulbar approach in the inframedial and the supramedial aspect of the globe after giving 2 ml of lignocaine. Retrobulbar ampho B was injected once daily for 10 doses and observed. Patients having absence of light perception, total ophthalmoplegia, obvious necrosis of orbital tissue, and worsening despite the above concurrent systemic management were taken up for exentration. Our results showed that out of 110 patients who developed mucormycosis, 36 patients had stage 1 infection, which were treated with intravenous liposomal ampho B. 74 patients had orbital mucormycosis, out of which 43 had stage 2 and remaining 24 had stage 3. We classified our stage 2 patients as 23 patients who presented within 48 hours of developing symptoms and 20 patients who reported after 48 hours of presenting symptoms. Out of these 20 patients who presented after 48 hours, 13 patients showed improvement while 7 progressed to stage 3. And out of these 7 patients of stage 3, 2 underwent exentration and remaining 5 succumbed to death. Hence, in stage 3 mucormycosis, altogether 12 patients underwent exentration, 10 succumbed to the disease, and 9 survived the disease. Thus, out of 74 patients where retrobulbar amphotericin B was given as an adjunct with intravenous ampho B, 45 patients had arrest of orbital infection with halting of the loss of visual acuity and subsequent discharge. The survival rate of retrobulbar ampho B as an adjunct with intravenous ampho B to patients presenting at an early stage of the disease was 60%, showing promising results. The clinical presentation of orbital mucormycosis is usually orbital cellulitis with proptosis, visual loss, and apical neuropathies. Brunet and Rammert have recommended liposomal amphob as a first-line therapy for treatment of the disease along with surgery whenever possible. A case report by Hirabayashi and others where they found that progression of orbital infection was halted and visual acuity was restored with eventual hospital discharge. To our knowledge, clearance of orbital mucormycosis with retrobulbar amphob injections have not been previously reported. Our study was done in the ongoing COVID-19 pandemic era, which itself makes it novel. Ours is a multidisciplinary government hospital with a dedicated COVID-19 facility and a tertiary ophthalmic center. Hence, diagnosis of rhinoorbital mucormycosis in the early stage needs a high index of suspicion to save both the life and sight of the patient, and early diagnosis with prompt, well-coordinated multidisciplinary approach is crucial. Intervention with retrobulbar injection of amphob may be a viable therapeutic option in cases of orbital mucormycosis who have presented early so as to halt the infection and help prevent loss of vision and subsequent exenteration. These are my references. Thank you.
Thank you very much.
How did you do the retrobulbar amphob injection?
As in the preparation of the drug, sir, or?
How
Delivery. Delivery is important here. How did you deliver
The drug.
retrobulbar
Okay.
amphotericin?
Sir, after taking all the aseptic precautions, we instilled a betadine drop and lignocaine 2 ml on the patient's ocular surface. We also explained the patient about the procedure. And then, with the help of 24 gauge needle, we inserted the needle in the infromedial and some patients in the supromedial aspect of the globe. Initially, we went 90 degrees and we tilted the needle to 15 to 25 degrees retrobulbary, and then we injected 1 ml of the drug.
That's what I wanted, because if you are using the needle, there is high risk of touching and damaging the
The globe.
intraorbital
Yeah.
structures, which are very vital structures are there. Instead of that, you could have used a Venflon initial introduction. After that, use the Venflon, which will be more effective for your delivery.
We made sure we could see the proptosis of the eye after putting the drug. Like in retrobulbar, if we go, we could see the eyeball a bit.
Yeah, but
coming
with
up, yeah.
needle, there is a risk of
Yes, true.
the soft structures and the vessels that is
yeah.
there in the retrobulbar area. Okay.
Yeah.
So when you use Venflon, it is smooth and less likely to cause any danger to the structures.
Okay.
Right. And how many at the entry are stage 1 and how many are in stage 3? For my interest, I am asking. Because stage 1, a lot of cases have progressed to stage 2 and 3.
Yeah, no,
Yeah.
in our case, stage 1 disease, we took at only PNS and nose involvement. So those were taken care of by the ENT side. We only managed stage 2, which progressed to stage 3.
Stage 3,
So we
yeah.
had some 20 patients in stage 2 who progressed to stage 3, and those were mainly those patients who presented late in stage 3. So they couldn't be controlled by the injection.
Okay.